it's the presenting view to me. So is it filling your whole screen?
Yes.
Okay, cool.
Yeah, and we're recording too, by the way.
Yeah, I can see that. All right.
Okay.
Good morning. We'll get going then. We have a fairly, I think, short presentation altogether. This is the protocol revisions for summer of 2022, and there are no earth-shattering, groundbreaking type of things. It's mostly cleaning up some issues and then discussing some of these issues as we go along. So first, I'm going to briefly go over the, and Dr. Mocht and I are tag teaming this today. Dr. Gadbois is in the wings and will join in as she wants to make comments. She would have been presenting this too, but was on call yesterday, and we never know with the on-call situation nowadays when she might have ended up working a night shift. So Dr. Mocht and I will be tag teaming this one. So we'll begin with the changes, which are quite minor in the county approved medication list. First one is acetaminophen suppositories for pediatric fevers, fever of greater than 100.4. And the dosing on that is, we have it as 20 milligrams per kilogram. It's basically 15 to 20 milligrams per kilogram. These things come as several varieties of suppositories. Remember, they have to be kept fairly cool because the basic rule is you can't put a warm, soft suppository in a warm rectum. It doesn't work. So the dosing, the suppositories come as 80 milligrams, 120 milligrams, 325 milligrams, and they also come as a 650 milligram suppository, but we won't likely be carrying any of those. So if the dose at 15 to 20 milligrams per kilogram, that is basically.
Dr. Whitworth, we lost your sound.
I'm sorry?
We lost your sound.
Oh.
Now you're back.
Oh, interesting. I wonder why that occurred. Okay. So basically, a 5 to 10 kilogram child would be taking the 80 milligram size. 10 to 12 kilogram child would be the 120 milligram size, etc. You can sort of estimate if you need to cut a suppository in half, just go ahead and do that. And it's always easier to use the bulleted end than when you're using it. Next change is on Atrovent. There's no change on the dosing, which is 0.5 in a 2.5 milligram milliliter, and then you nebulize this. Now, this is for bronchospasm, wheezing. It's the initial treatment only. We are not having you not, and we'll go over this again later, we'll have you not use Atrovent along with albuterol on any subsequent treatments. It's only necessary for the first treatment. There's no advantage, and there may be a disadvantage besides cost. There may be a disadvantage to using more Atrovent. Haldol as an alternative. The dosing on Haldol is 2 milligrams to 5 milligrams, IV or IM, and an IV, of course, you give it slow. You may repeat every 15 minutes to a total of 10 milligrams maximum. PEDS dose is 0.1 milligram per kilo. Now, we'll later on be discussing, we would prefer most sedation in children under the age of, let's say, 10 would probably be best with midazolam. Ketamine, we
And
have
Dr.
made,
Whitmer, okay, if I jump in with a quick clarification there.
sure.
And so what we're getting at here is that droperidol, when you're looking for a neuroleptic medicine to sedate someone, droperidol is preferred. The reason for that, it's quicker in onset, shorter in action, and it's on label for IV use. So droperidol is the preferred agent, and Haldol is the alternative.
Ketamine, there's no evidence showing that so far we cannot find any scientific evidence showing its greater efficacy in a shock state. And so we simplified the dosing a bit. We've dropped out the recommendation that you use it in a shocky person. And the reason is that essentially by the time they're in shock, they're depleted of catecholamines anyway. So if you have a sympathomimetic drug, it's really not going to make any difference. You really need to give pressor support at that point. Ketamine, simplified the dosing. We're continuing for sedation during RSI and for DSI, 2 milligrams per kilo with a max of 200. So we've established 100 kilogram max. And then for sedation, for CPAP, pain control, and adjunct with fentanyl, 0.5 milligram per kilo, IV or IO, with a max of 25 milligrams for any dose. And then for, this one we should drop out. This is going to be dropped out. We're not going to give it, we're not going to recommend IM for pain relief only without fentanyl. We missed that in our review.
No, but that's, and no, Mark has made those changes. So both of them say pain control adjunct with fentanyl.
Right. Zyprexa, we're carrying the 10 milligram ODT, and this is for the adult with psychotic symptoms or mild agitation. So that's to replace the 5 milligram that was in the previous thing. Now for North Country only, we have TXA, tranexamic acid, and that's a gram in 50 cc's over 10 minutes. Now we may be adding this in December. I'm considering adding this in December in the next iterations change. That we'll get a we'll have some more discussion with the trauma surgeons. Right now, it's being used appropriately in North Country for trauma shock to be. They have a longer transport time, so we may be adding it here as well, depending on whether the trauma surgeons buy into this. Guidelines for PPE. This is our universal guidelines now. Minimum PPE for all patient contacts will include gloves, eye protection, and a surgical mask. Use an N95 or higher level of mask during any aerosol generating procedures or during transport for the person in the patient compartment if the patient cannot wear a mask due to EMS provided treatment or at the choice of the provider. Many of you are reasonably saying if I'm around a patient in close contacts, I'm going to wear a higher level mask. But the minimum is a surgical mask. This will come up in our discussion of monkeypox too. Allergic reactions, I've changed the anaphylaxis allergic reaction to give 0.3 milligram epi-IM, as well as to start an epi-drip if there's a severe reaction. I know we've had essentially that in the past, but after our discussion with the last month with the allergic reaction that was treated with IV epinephrine, intravenous epinephrine at a very low dose rate that would be not enough to actually provide um, uh, complete coverage for anaphylaxis. So just to reiterate then, for your allergic reactions and anaphylaxis, a mild reaction, and that's defined as generalized itching and hives, skin signs only, no respiratory signs, no cardiovascular signs. Benadryl, 1 milligram per kilo IV, or you can give it IM if unable to start an IV, or by mouth to a max of 50 milligrams. Now, for a severe reaction with dyspnea, wheezes, laryngospasm, angioedema, shock, start out with epinephrine 1 to 1,000, 0.3 milligram IM, or if you have an auto injector. I don't think anybody in the county is carrying epi auto injects because we've trained all the EMTs, all the basic EMTs to give 0.3 milligram IM. Now you can repeat that IM dose in 10 minutes if there's no advanced life support there, and so an IV drip is not available, or if you can't get it because of the severe shock and you can't find a vein. And if the patient still has severe symptoms, in 10 minutes, you can repeat that 0.3 milligram IM. However, my preference is, of course, after you give the 0.3 milligram IM for your immediate treatment, then you start your IV, and then you start an epi infusion and start at the low dose, 2 mics per minute. And depending on the patient's symptoms, you can increase it by 2 mics every minute to the clinical response. You will give a fluid challenge if they're in shock. Benadryl 1 milligram per kilo IM. You can start an albuterol med-neb, but that is not the first thing you're going to start. You want to get that epinephrine into the person first. And then Solumedrol 125 milligram IV. The alternative to that is dexamethasone, either IV, IM, or PO at 10 milligrams. Solumedrol can only be given essentially IV. You could give it IM, but it's poorly absorbed, so IV. And then norepinephrine as needed if they're in profound shock. Now, my guess is you will already have the patient out of anaphylaxis at that point. Now, I'm going to take a step backward because in the past, I have said if the patient is not in extremis and you can get an IV in and they're an elderly patient, it's a very elegant way to treat them with epinephrine as a drip. However, as we found from last month's case review, sometimes people start them at the 2 micrograms per minute and then just never change it. And if you do 2 micrograms a minute for 60 minutes, that's 0.12 of epinephrine, which is not enough epinephrine to actually deal with anaphylaxis. So that's why we want to get the 0.3 milligram in and then add more by the drip as needed. All right. Slight changes in acetylene PEA. No, even though we have highlighted this is not, so sodium bicarbonate, adults get 1 milliequivalent per kilo for acidosis, suspected acidosis. Peds get 1 milliequivalent per kilo IV. maximum is 50 milliequivalents at one dosing. Now you may have to repeat it depending on what the situation is. So when do they have acidosis? Well, you can assume acidosis if it's cardiac arrest, probably due to respiratory compromise, such as COPD exacerbation, congestive heart failure with low O2, with extreme hypoxia. So in the toxins, tricyclic antidepressant or Benadryl overdose, sodium bicarbonate, 1 milliequivalent per kilo, PEDS, 1 milliequivalent per kilo as well. Added beta blocker to the calcium with the calcium channel to give calcium gluconate.
And if I just to clarify the reason behind the bicarb for tricyclic or Benadryl, in that case, you're not giving it for acidosis, you're giving it because both of those are sodium channel blockers. And so you're overcoming the sodium channel blockade with sodium.
Correct. Cardiac arrest, VFib, pulsus, VTAC, pediatric patients. Follow the adult algorithm flow. And for ALS, BLS providers use pediatric pads with the adult AED algorithm. And with ALS providers, defibrillation is 2 joules per kilo for the first attempt and 4 joules per kilo for subsequent attempts. Epinephrine doses, amiodarone, lidocaine were their initial things. And with sodium bicarbonate, we already mentioned any changes in that. Hyperkalemia, calcium gluconate, 3 grams, slow IV, flush the tubing, because then you're going to give bicarbonate, and bicarbonate and calcium together make rocks. So sodium bicarbonate, 1 milliequivalent per kilo, slow push. Now your IV fluid of choice in hyperkalemia would be balanced salt solution, not lactated ringers, because of the lactate has some bicarbonate in it at that point, so that, but very minimal. So balanced salt solution would be your choice there. And then, so those are the important things in the hyperkalemia. Less important, but easier to do, is albuterol 5 milligrams by continuous med-neb with a max of 20 milligrams. Now, you're going to have the IV, the basic EMTs can set up the albuterol IV, the albuterol med-neb while the paramedic is setting up the calcium gluconate. Follow your protocols for dysrhythmias. Let's see if I can move this ahead now. I don't know how I can go down there. Let's see. Oh, good. Pain control. The fentanyl, max single dose increase. So the dosing for fentanyl is 1 microgram per kilo, IV, IO, or IM, with a max of 100 micrograms per dose. And that can be given at a Q 3 to 5 minutes, depending on the patient response, and it's 300 micrograms total before you have to call. If you're in North Country or someplace where you're making a super long transport and you need more, you can call medical control for the concurrence. Avoid opiates in chronic pain syndromes. So use for acute painful situation. A chronic pain syndrome would include migraines. Now, rapid injection of fentanyl may cause respiratory arrest, causes a rigid chest syndrome. So give it slowly over 30 to 60 seconds. That also reduces somewhat the likelihood that they're going to get nauseous.
And Dr. Webb, would it be okay if I jump in with the rationale for that?
Of course.
And so our goal here is to make sure that we're maximizing the use of fentanyl before we're adding in anything else, but especially ketamine. This doesn't mean that everyone who's 100 kilos needs to get 100 micrograms per dose, but we wanted to give you more latitude with the dosing, and just give you the ability to treat acute pain with fentanyl.
Now remember, fentanyl in certain situations may want to reduce the dose of fentanyl, like older people, I mean really older people, frail people, very little people. But of course, if you're dosing it by kilogram, that's much safer. Fentanyl can cause some slight decrease in blood pressure, but not as much as midazolam, for example.
And I would add one additional thing is that other considerations for reducing, not giving them the full 1 mic per kilogram, besides the points mentioned earlier, is if they are under the influence of other opioids or sedatives, such as intoxication, or if they're opioid naive. I think that you can administer whatever you'd like, and if you would like to add a little note about why you gave them a reduced dose or something like that, that'll help us when we're reviewing your narratives. But ultimately, as long as you remember, if someone asks how come this dose, that you remember the rationale.
Yeah, my basic rule has always been, if you're doing IV medications, IO medications, IV medications, I'd much rather see you give a small dose twice than give a large dose and then worry about the side effect.
And you know how Dr. Maka just mentioned that we want to maximize our pain control before moving to other agents. And this kind of comes from recent experiences where the clinicians have had patients that have been given ketamine before we've maximized our fentanyl doses, and they're so obtunded that they can't get a history or physical reliably, and they end up getting a workup that may not have been necessary.
Right, and so therefore, this is a good segue, or as Mark says, a segue into ketamine. Ketamine, we've simplified the dosing, and it's an adjunct for pain. So ketamine, adjunct with fentanyl, you must have given at least 2 doses of fentanyl. Now, I've reviewed all the ketamine given over the last 2 months. And when it's being given for pain, almost universally, we're underdosing the fentanyl before we give the ketamine. So you've got 100 kilogram young man getting 2 50 microgram doses of fentanyl, and then he gets a dose of ketamine. Not surprisingly, they don't have that much pain relief. And also, just as a reminder, when you're treating for pain, we need to see the pain score before and after your treatments all the way down. So if they've got a pain score at 10 at the beginning, and then you write in your narrative improved, or you write in the flow sheet improved, but you don't put a pain score, I don't know that that's improved. We need to know what their pain scores are. So ketamine is an adjunct with fentanyl, must be given at least 2 real doses of fentanyl. So, and if you say, well, I'm uncomfortable with that, I'll tell you that Multnomah County and the consortium in the 3 counties around Portland, that they're to give a maximum of 300 to 400 milligrams of fentanyl before they give any ketamine. So we're a little bit more liberal and a little bit more generous with the ketamine because I think there's some downsides to giving too much fentanyl as well, usually in the nausea. So dosing is 0.5 milligram per kilo IV over 2 to 3 minutes. Give it slow with a max of 25. That's no change. May repeat every 10 minutes to control pain or if patient develops nystagmus, etc. It can also be given IM, but the max dose IM is 50 milligrams. Now, I don't see any real reason to give it IM ever, because you could, the only thing is if you maybe had a patient that in a trap situation and you couldn't, and you were giving them IM fentanyl or IN fentanyl and you couldn't get into the, adequately get an IV going, but it's be pretty uncommon. If you have emergency reactions, low dose midazolam, 1.25 to 2.5, 2.5 for the average adult, IV or IM will usually take care of their emergence. Now here we are back on the respiratory distress, and on albuterol, we want you to, when you're using MedNabs, to repeat the albuterol, but not the Atrovent for bronchodilation, because the Atrovent, it's really a waste of your time and money, and it may cause some actual difficulties. So albuterol 5 milligrams with Atrovent via the MedNab, the first dose, and then repeat albuterol only, which means that if there are any agencies out there, we checked, and I think all agencies carry both the combination albuterol and Atrovent, or albuterol separately and Atrovent separately. So you can always give albuterol by itself. Seizures. Definition of febrile, 100.4. So anything above 100.4 and above is a seizure. Now, pediatric patient. If the patient is in status seizure, defined as a continuous seizure or repetitive seizures without regaining consciousness, or a simplistic way to look at it is if you arrive and the patient is still seizing as you come in the door, that's a continuous seizure or a status seizure as far as I'm concerned, because that's been at least that child, particularly that child, has been in a seizure for a minimum of 10 minutes at that time. By the time you figure out the dispatch time, the call time, the transport, the arrival time, and then the at patient scene. If you arrive at patient and the patient is still seizing, you can start midazolam. Midazolam is 0.2 milligram per kilo, IV, IO, IM, IN. Repeat every 5 minutes until the seizure stops. Makes it very much simpler. Monitor patient's respiratory status. If fever greater than 100.4, you treat the seizure first and then cool the patient and give acetaminophen suppository. Marlo, is this where you take over?
Yes, so I'll go ahead and take it from here.
Yeah, I got to do my stop sharing, I think.
If you're okay with it, I just took control of the slide show from here, so I'll just present from here. So with respect to stroke, this is just a process update. So if LAMS 4 or 5, in other words, a candidate for neurointervention for LVO, check HOSCAP status for the availability of the neurointerventionalist. If the neurointerventionalist is unavailable at PeaceHealth, then you would divert to the closest appropriate comprehensive stroke center on the other side of the river. Those are Emmanuel, Providence, Portland, Kaiser, Sunnyside, and OHSU. If that's not practical due to traffic, then contact medical control for direction.
Yeah, we'll have to, the reason of that is we've, all the hospitals, including hospitals in Portland that are stroke centers, interventional stroke centers, have been having some difficulty with personnel, and in the month of August, and also less in September, the neurointerventionalist is unavailable at PeaceHealth. Now, we do have the time, we do have the days that we do know the days they're going to be on, and the times that they're not going to be available, and those are posted. And then in the HOSCAP, they will list that the neurointerventionalist is not there, so you don't have to remember all this stuff. But for daily, when we're going to have a problem with the neurointerventionalist, we should be able to pre-warn you of that. Now, that's not unique just to PeaceHealth, but we work in the Clark County system, and PeaceHealth is where our neurointerventionalists would know, and those large vessel obstruction strokes would go. So the same thing has happened in Portland. Emmanuel was down several days in Portland. Also, Portland Providence was down, and Sunnyside was down. So I guess now is the time, if you ever want to get a good job with guaranteed thing, when you become a neurointerventionalist, because they're in high demand.
No, and it's often the same doc that's covering. There's a doc that goes between Emmanuel and Sunnyside, and so and just a note that will show up as in the comments on the stroke. So PeaceHealth will still show as open for stroke, but it'll have a comment about neurointervention. So with respect to post-intubation sedation, we made changes that parallel the changes that we made with pain control. So we have fentanyl. So the key point here is analgesia first, then sedation, because getting proper analgesia after intubation is going to decrease your need for sedation. And that ultimately, the less sedation that you're able to give a patient, you ultimately decrease ICU delirium, decrease their time on the vent. So analgesia first with fentanyl, 1 microgram per kilogram IV with 100 micrograms per dose. Unlike the pain control, since these patients are already intubated, there's not a max dose. Although, typically with most patients, after you've given 300 micrograms, that's probably about as much pain control as you're going to get. The places where I'd consider going higher are if you have someone who's intubated and then also has an extraordinarily painful condition like a burn or a long bone fracture. And then the sedation is with ketamine, 2 milligrams per kilogram is a slow push, max 200 milligrams in a single dose. So you're going to begin that 15 minutes after the induction dose, unless there are signs of inadequate sedation after adequate analgesia. So in other words, you can move that up if there are signs that the patient's inadequately sedated and you've already done what you can to control their pain. Keep in mind that if you use a long-acting paralytic for intubation, that you're not going to see signs of inadequate sedation. So definitely err on the side of sedating earlier and generously. And then the alternative for only if ketamine is not available is midazolam. And again, the reasoning for that is that patients who get benzos post-intubation tend to have more ICU delirium, longer length of stay. So our preference is for ketamine in pre-hospital setting for post-intubation sedation.
And also midazolam will inevitably produce some hypotension, particularly if it's being used post or during, traumatic shock or post cardiac arrest. So.
Agreed. Okay. With respect to agitated patient management, the olanzapine dose, as we mentioned before, is increased to 10 milligrams. Just so keep in mind, if there's a patient who has some psychotic symptoms, but also has some depressants on board, whether that be alcohol or benzos, use a little bit of caution with that. You can get some sedation with 10 milligrams ODT, but in general, the goal here is to make your transport less eventful, and then the hospital course less eventful. And you can definitely, within 30 minutes of getting this, you can start to see patients that are having some hallucinations, having some psychosis and paranoia. They will start to tighten up. Tighten up meaning get a little bit less psychotic. We're replacing the term excited delirium with severe agitation. It's because in general, there's enough controversy and disagreement in the medical community about exactly how to define excited delirium, that it's become a term that's hard to use and define. And so we're just using the phrase severe agitation. And so, as we mentioned before, the decision making there is around the degree of threat that the patient poses to you, to themselves, and to other people. And then finally, a reminder, olanzapine only is in ages 18 to 65, and it is okay to give that prior to transport to an alternative mental health facility.
And although just be sure to tell the patient that they don't swallow that pill. That's an oral dissolving tablet.
So we've made an update with the acute MI suspected and STEMI early response protocol. So this is because likely within the next year, Salmon Creek will start accepting EMS STEMI patients. That is not yet, and we will notify you when that changes. September 19th is when we're going to start doing walk-in. Like if someone walks in with a STEMI and we have the cath lab available, we'll start keeping them there. But we have more work to do to be ready to accept EMS STEMI patients. We want to come up with a smooth process for notification. So always check the HOSCAP status for availability to accept the suspected STEMI patient. So that means that if Peace Health has multiple patients on the table, they may temporarily be unavailable. Our preference will always be for a Clark County hospital, and then if a Clark County hospital is unavailable, then we'll divert to a PCI capable hospital in Portland, Emmanuel, Providence, Portland Adventist, Kaiser Sunnyside, or OHSU, and then with the caveat that contact medical control if that is not practicable due to traffic or other reasons. With respect to hospital divert status, the divert status will be given to the paramedic by CRESA or by looking at, if you're looking at the HOSCAP app, you can see after you've evaluated the patient and you're ready to determine your destination. And then we've just made a clarification. There's no change with respect to what we said for Peace Health. The Peace Health will accept trauma entry, STEMI, cardiac arrest, stroke, and sepsis when on ED divert. And we just had never specified although it's been our practice that Salmon Creek will accept sepsis alert stroke patients that meet criteria. And then when PCI is available, we will add that as well. But again, you'll have ample notification when Salmon Creek is available for pre-hospital STEMI patients. I'm going to make a brief note here. The metro area is working on a process to reduce ambulance diversion, and we'll be giving you more information about this. They're essentially one piece of it is essentially adopting what we do here, which is that if all the hospitals in a zone are red, then none of them are red. But what there are plans to do in the future with HOSCAP is to actually just make that change on HOSCAP. So both hospitals go red, then they automatically both roll over to green. And then the other change that they're proposing is that each hospital is limited to 2 hours on divert. And then if you go on divert for 2 hours, then you need to be off divert for at least 2 hours. There'll be a trial for that. And then based on the results of the trial, that'll be coming out. Again, there'll be more communication when that's operational. But the first trial is tentatively scheduled for October 6th through 12th. Dr. Whitwer, did you have anything else to add to that?
Oh, EMS just needs to be aware of that. It should not affect our situation only. It'll just affect what the HOSCAP looks like. It'll be green more than it'll be red.
Yeah, but functionally, it's what we're doing already.
Right, exactly.
We've already done education on this, but we've added a section on interacting with midwives to the protocol. And so I'm just going to hit the key points here as a reminder. So the presumption is when EMS is contacted that there is an emergency. As we discussed, midwives have an obligation to involve a physician when there's a deviation from normal with childbirth. And so you're operating as our designees in this situation. I see that question in the comments. I'm going to go through the midwives and then we'll address that. So that's either fetal distress, maternal postpartum hemorrhage, or newborn respiratory distress. The midwife is likely going to be the most experienced person on scene with respect to childbirth. And so we want to make use of their expertise and then the medications that they have that we do not. The midwife can be in attendance of the patient with EMS assistance, but EMS retains scene control. The midwife does not direct EMS, but EMS can assist the midwife and can perform procedures within the scope of practice. There's nothing that the midwife should be directing that deviates from your established protocols. And if there are any questions, contact medical control. Okay.
Question about that.
So there, I'm going to read the question so everyone can know, and then I'll ask Dr. Whitwer or Mark to address this. Will CRESA know whether Portland hospitals can accept LAMs 4 to 5 or STEMI if Peace Health is down?
No, CRESA will know that, but we don't contact CRESA for that kind of direction anyway. Your HOSCAP will tell you whether those hospitals are up. The hospitals that are STEMI centers in Portland and stroke centers follow the same rules that we do, which is that our stroke center and STEMI center, even if the ED is on divert, they still accept the STEMIs or the strokes or the sepsis alerts. But so in the HOSCAP, it will tell you if a manual cath lab and if a manual is up for STEMIs, and if the cath lab is full it'll say so. Same thing for Providence, for Portland Adventist, etc. So ordinarily you would go to the closest. I would suggest you go toward the closest hospital in that, as you go over the bridges from the east, go over 205, that Adventist and Portland Prov are the closest. If you go over the I-5 bridge, then you've got OHSU, you've got Emmanuel, Portland Prov, and OHSU to choose from. So now I'm working out with and it only counts for our side. I'm trying to set up a system so that when you call a STEMI, that you can still send that by Pulsera. You can send that your 12 lead to the ED at Southwest so that they can overread it for you and agree or not agree that this is a STEMI. So because many of the STEMIs are not called because the ED physician does not agree it's a STEMI. Sometimes they make a mistake on that too. But we're trying to give some way to, but Dr. Gadbois and I are working on trying to increase your familiarity and your comfort with reading STEMIs in the field and reading 12 leads in the field. To wit, we will be sending out monthly quizzes, not quizzes, but sort of educational things on, is this a STEMI or not a STEMI, based on actual cases from our transports. And this is going to be a significantly less issue when Legacy comes on board. Legacy Salmon Creek comes on board. Then we'll have 2 STEMI centers that are available in the same county.
So going back to the protocol update, we've updated the county operating procedures to include the MCI protocol. There are no major surprises, just designating the National Incident Management System to manage MCIs. And that there will be a unified incident command, which depends on the primary hazard of the event. So different unified incident command for a shooting versus a hazmat spill versus a medical only incident. And then, but the lead agency could change as the priorities of the incident change. And so it makes reference to the MCI protocol. It's not a set number of patients, but just the fact that the resources required exceed the resources that you immediately have available. So it can involve, as an example, multiple asymptomatic patients. During a declared MCI, the trauma system is not in effect. Licensed ambulances are not needed for transport. And if transport resources are limited, more than one critical patient may be placed in an ambulance. And then there are detailed descriptions of roles and responsibilities in the MCI protocol. We made a housekeeping change to racemic epinephrine. It made some mention that it's only used or rarely used outside the hospital. That's obviously not the case, but this is only a housekeeping change. And then just a few more general housekeeping changes. So I added Dustin Walliser as training captain for Fire District 3. We removed the access number for the SERV van. That's been out of commission since early in the pandemic, and there are no immediate plans to reinstate. We removed the protocol for transport to the sobering center, because they have combined their resources with detox to offer the same service. And we clarified the dosing of calcium gluconate for calcium or beta blocker calcium channel or beta blocker overdose and hyperkalemia, that the dose is given in grams rather than in milliliters. And then clarify the pediatric trauma diversion, where for purposes of trauma, we're defining a pediatric patient as less than 15 years old. And those are all the updates we have. Dr. Whitwer has some additional information on monkeypox, but any other questions right now on the protocols? Great. And Dr. Whitwer, I'll give this back to you.
Okay, and I'll try to get my monkeypox up here. Okay, can we see monkeypox?
Yes.
That's a married monkeypox there. All right. You all have been watching and listening and with some interest over monkeypox was sort of the cause celeb for the summertime. This is for information only because the nice thing is that it doesn't affect what we're doing already and how we manage any patients who might have the monkeypox. It's a virus disease. It's infection with the monkeypox virus. It's the same family of viruses as smallpox or variola. The symptoms are similar to smallpox, but milder and rarely fatal. It's sort of like cowpox was in the 16th, 17th, 18th, 19th century. They cause very, very rare symptoms, mostly just the pox. Incubation period, just like smallpox and most viruses, is 7 to 14 days. Illness duration is 2 to 4 weeks. But the contagious time of monkeypox is from the time you first start to get symptoms until the rash is fully healed. So in that sense, it's just like chickenpox in that during the prodromal symptoms time, when you're starting to get sort of stuffy nose, etc., that you can then pass it. But as soon as you have the active lesions, they can be spread. So fomites fomites are the classic spread of this. Direct contact with clothing, with blankets, etc., etc. So, and until the chickenpox or monkeypox has totally crusted over and you've got fresh skin under this, those crusts are contagious. Now, how do you spread monkeypox? Mostly by large respiratory droplets with prolonged face-to-face contact, doing intimate physical contact, kissing, sex, etc. Direct contact with skin lesions, direct contact with bodily fluids or contaminated clothing or bedding, direct contact with infected animals or animal pox. They call it monkeypox because the monkeys get it. Other mammals can also get monkeypox. Now, presumption of monkeypox is reported contact with the person who had a similar rash or was diagnosed with monkeypox. So the patient will tell you, "Oh, this person had called me and said that they've got this rash on them now, and now I'm starting to get, or seeking care for a rash possibly associated with sexually transmitted infection. Close contact with individuals in a social network experiencing a monkeypox outbreak. So it's quite common in homosexual communities, men who have sex with women primarily, partners meeting through online websites, digital apps, parties, bars, etc. So the usual kind of thing of spreading sexually transmitted diseases. Travel outside the U.S. to countries with confirmed cases of monkeypox.
And Dr. Whitman, could I add a detail there?
Sure.
That in the current outbreak, 98% of the cases have been in men who have sex with men. So it doesn't mean that people that aren't in that demographic can't get it, but that has been the vast predominance with the current outbreak.
And a lot of them have very, very painful and very troublesome genital lesions. Monkeypox. Now, the nice thing is that for us, if you think you have monkeypox, well, you don't have to think they have monkeypox because your PPE requirements are the same as every other patient contact, which is an N95 or equivalent mask, gloves, gown, and eye protection. So you're protected against droplets by your mask and your eye protection. You're protected against contact with skin, contact with clothing, contact with bedding because you're wearing gloves. So you just do what you're supposed to do for all patients. So you just don your normal standard protective equipment, treat the patient with universal patient care, put a surgical mask on all patients. Remember, they are spreading respiratory droplets. And you're going to let the receiving facility know that you're, actually you don't have to worry about that. You're unlikely to be having an airway problem with monkeypox. You're unlikely to have to provide them supplemental oxygen. You're unlikely to have to provide assisted ventilations, but it doesn't make any difference because your personal protective equipment is, and then when you doff your equipment, you do it carefully and the way you've been taught to do it. And then you really have no worrisome exposure issues. Give pre-arrival reports to the hospital, including if you have a suspicion of monkeypox. Don't shake any contaminated bedding. Disinfect all surfaces. And clinical care for monkeypox is mostly supportive care and isolation product. And then and then the CDC has been using a lot or authorizing a lot of what are basically experimental drugs, antivirals on the monkeypox, and which apparently have been working with good effect with very little side effects. But that's the history, that's the story on monkeypox, and you really, have to be aware of it and take your normal good precautions.
And so what I would say as you're thinking through this, so keep in mind that someone can be contagious before they have pox and they're going to have a viral prodrome. So it makes just as with COVID, it just makes sense that if someone is having a viral syndrome with fever, body aches, that you wear a gown. I mean, that's the one thing that's not specified in every patient encounter, but I think every patient that is presenting looking like a viral syndrome, it makes sense to wear a gown. And we've had, I believe, 4 or 5 cases in Clark County, so it's not a lot. And I've seen more panic about monkeypox than monkeypox. So my takeaways would be use a gown, take contact precautions if you've got someone who has a viral syndrome, and then keep in mind that things that are specifically concerning for monkeypox are the viral syndrome, and then 2 days later you start getting pox-like rash, and so that's so it doesn't mean that everyone with a rash is ruled out monkeypox. It's this very specific viral prodrome and then a pox-like rash. So hopefully that can limit the concern around the monkeypox.
The poxes are so obvious, just like chicken pox. You get almost like a little blister, but it's umbilicated. It's got a little dimple in the center generally, and then they ultimately break and they make the crust. Okay, I think that's the end of the slide section. So does anybody have any other questions? Do we have questions in the chat that we haven't addressed?
No, there's no more questions in the chat box.
All right. Then just as a reminder, Dr. Gabois will be doing case reviews on the last Tuesday of the month. And that's it for today then.
Thank you.
Thank you.